Let's take a look at hip mobility. So oftentimes with a patient in supine, we can bring the patient's hip up into flexion, then we can look at this little of an arc of a motion. I think about her knee, maybe starting flexed a little bit abducted, externally rotated, kind of neta ipsilateral axilla, keeping her nice and tight in flexion, swooping her thigh across her abdomen towards her opposite armpit into, besides hip flexion, into internal rotation and relative adduction. Lots of patients lose the ability to get into that internal rotation, horizontal adduction, flexion pattern. So it's quite common in therapy that we need to try to mobilize the hip to restore that combined motion of flexion, relative adduction, internal rotation over here. So this is my pre-mobilization asterisk. I'll say how much motion and what's the quality of that motion to myself and to the patient coming across. How tight can I keep their thigh, or do I feel like I get pushed out? Is there a nice round arc, or is there a nice round arc here and then it flattens off on the other half of that arc? So that looks like, if I show you on the skeleton first, this will be a little bit awkward, but I think you'll get the idea. I'm going to have this belt as far proximal as I can on the femur, trying to get towards the hip, and then I'm going to bring that hip into its end range of flexion, AD, and internal, and then I'm going to pull, right? Look at the angle of this strap. When I pull with my hips, I'm pulling a little bit lateral, but mostly I'm pulling posterior and inferior direction. So I'm pulling posterior, inferior to try to restore this flexion, internal rotation kind of a motion. So I'll do this on the model's hip in a second. Okay, let's just put that next to there. Okay, so then your leg back up.
Okay.
I just like to add a towel for a little extra layer of padding with these mobilization belts. Put the padded part relatively high on the femur. Go to her end range position, so she's going to be flexed with a little bit of internal and adduction, right? And then I'm going to pull primarily with my left hip myself. And if you look at, let me change this towel for a second so I can see the strap better. You can see that strap angle better. If you look at the strap here, if I pull with my left hip, you can tell the direction I'm pulling her hip is posterior, inferior, and a little bit lateral. And it's key that I don't back off with her end range position. So it's almost as I pull with my hips, I'm pushing her knee towards her opposite armpit. What you don't want to happen is as you pull with your hips to bring her out of that position, like so. So make sure you keep her at the end range and then mobilize from there. Check your foot position. I like my back foot to be really close to the table. If I switch to my feet, it's not going to work as well because now I'm pulling her lateral. I can't pull with this hip. So my back hip is the one that's close to the table, my back foot, and that gives me that posterior inferior direction with the pull. So then after you mobilize, you should be able to recheck the motion right away, right? For both quantity of motion and quality. So again, I come up on this ipsilateral armpit axilla into flexion, stay nice and tight, and then I sweep right across. And I ask the patient, does that feel better, worse, or no different? Usually they say it's better, maybe still a little bit pinchy at the end. If that's the case, I would do another round and reassess. But you should get pretty dramatic results within one round of mobilization to increase this quadrant of motion. Good.